Hello, everybody out there in TV land. This is Morgan Denny, lead faculty for the Primary Care PT Division for ICE, and this is the ICE Daily Show. We today are going to talk about a research article that came out in 2019 about the updates on COPD, chronic obstructive pulmonary disease. And while it's not something we talk about a lot as physical therapists, it is something that we are going to see and that we need to get better at screening for and helping to assist with. So from the article that came out, which is literally called an update on clinical aspects of COPD disease, this was in the New England Journal of Medicine just last year. They basically talk a lot about the changing factors and characteristics that they're seeing in COPD and kind of how it relates to a preventative factor, and also what we can do and what we can look for. So I want to talk a little bit about what the article says and who's really developing COPD and what we can do. And then I want to talk about what we as PTs can really be doing and what we need to be looking at for these patients. Additionally, with the aspect of COVID-19 currently, there are going to be some changes and some things we need to get better at. So we'll do a short discussion on those factors also. So I want to start with the end in mind. So at the end of this article, the update on clinical aspects of COPD, they say this: in conclusion, we now understand that COPD is more a syndrome than a single disease. The recognition of pre-COPD and early COPD as targetable entities should help guide the development of specific therapies for these stages of disease, which may significantly reduce the incidence of severe COPD. So basically saying we as clinicians, everybody as clinicians within the medical system, we need to get better at being able to identify some of these patterns, some of these people, because early treatment, early strategies, preventative care can really decrease the severity, can increase those people that end up on supplemental O2. So the article kind of goes through and categorizes. So to give you kind of an idea in terms of is COPD really like a thing that I'm going to deal with? Is this something I'm going to see in the clinic? Well, totally, yes it is. COPD is actually the third leading cause of death worldwide, which is higher than I actually thought it was. I thought it was more in maybe top 5, but it's 3. It's number 3. There is actually 3.2 million deaths related to COPD in 2017, which is probably going up, and the worldwide prevalence is actually 10.1%. So if you think about it, that's 1 out of every 10 people on this planet have COPD or will develop it. And while the prevalence is actually the highest in China and India, which you can relate to environmental pollutants, but also more heavily smoking, we're number 3. So the US is number 3 in terms of number of cases of COPD, so we're not far behind. And we need to be working on that. The world needs to be working on these things. All right. One of the other components that this article talks about is how COPD really is an underdiagnosed condition because we all associate it with age. And they're fairly poignant in the way they say it, so I'm just going to read it directly from the article. So they say, COPD remains underdiagnosed, primarily because it usually is considered to be a disease of the elderly. The disorder should be recognized at an earlier age because earlier interventions, such as smoking cessation, can normalize lung function decline. They go on to say, thus, earlier disease should not be confused with milder disease, which I think is so good. So again, earlier disease should not be confused with milder disease. The former is related to age, whereas the latter relates to the severity of airflow limitation. Right? So remembering that these things can present themselves in patients who are younger. We're not just looking to the 65 and 70-year-olds who have been smokers for 40 or 50 years. Like, these kind of things can show up in younger patients. And while we tend to relate COPD with those older people who have more comorbidities, if we can start thinking about it as we see younger patients, especially who are smokers or who are being exposed to secondhand smoke, we can catch these things earlier and help keep these people away from the more severe repercussions. So for anyone who doesn't know, or if you're not familiar because it's been a while since PT school and you haven't thought about this stuff in a while, the general symptom presentation of COPD are shortness of breath, wheezing, coughing, excess sputum in the chest cavity, a lot of times in the morning, which can create more like clearing of the throat, or also coughing. These people really do display that increased respiratory rate that goes with the shortness of a breath. You'll also see a lot of fatigue, especially in the early cases, because they're not able to oxygenate the blood as effectively, right? So they're fatigued because they just aren't getting the resources they need to the tissue. But later cases, you're going to see more dramatic things, like you can see bilateral lower leg swelling in people. You can see chest pain, and again, just a higher level of that dyspnea, that shortness of breath. So those are kind of the symptoms that you would see or you would expect to see in someone with COPD. The risk factors, the biggest risk factor is smoking, really, but secondhand smoke comes in pretty close behind. And people who are exposed to environmental pollutants more often. Now, this could be a work situation. It could be you live in a high density populated city. Like I know if I would ever fly into LA, it's like flying into a cloud, but it's not a cloud. It's just grossness. Anyway, those are environmental pollutants. Those sit in the air and we're breathing them in all the time, and they can create some level of lung tissue damage. So it's important for us to kind of think about those things so that as we're treating a patient for low back pain who's presenting with some shortness of breath or is saying they're really tired all the time, again, these are things for us to think about and ask those questions. Are you a smoker? Are you in a situation, an environment that could preclude you to having some of these symptoms, or that is exposing you to environmental toxins of some form or another? In countries where there's a lot of cooking that goes on inside, people who get exposed to just literally the ash from the fire and the smoke constantly all day, because they always have a fire going and they're cooking, they often develop COPD and other type of respiratory diseases just because of that chronic exposure. They're not smoking like a cigarette, but they are smoking from wood smoke and charcoal all day long, so they can develop those type of factors. This article also goes on to talk about patients with COPD having other coexisting conditions. So the most common ones include ischemic heart disease, atrial fib, heart failure, osteoporosis, lung cancer, GERD, anxiety, and depression. And they say most of these disorders are characteristically seen in the elderly, but in patients with COPD, they occur at younger ages. So just keeping in mind that there's these cluster of things that could come with COPD or might preclude the diagnosis of COPD in a younger population. So if you're seeing someone and they have a little bit of these, like the diagnosed AFib, and they have depression, anxiety, and some other factors, and you notice that their respiratory rate is a little high, they're a little bit wheezy when you're exercising, this is something you might keep in the back of your mind, or you might refer them back to their primary care provider to get assessed to make sure they're not developing COPD or that their risk level isn't too high. So it's super, super important. A lot of the things this article talks about are some newer recommendations. And these are more for people who are already diagnosed with COPD, which are definitely the patients we're going to see as well. We're not always going to be the ones like catching COPD at the doorstep and preventing people from developing these severe symptoms, but a lot of times we get patients that come in who already are diagnosed with COPD. So there are definitely things that we as PTs can do to kind of alter our treatment strategy, and there are things that this article recommends that are not for us to do, but for us to understand so that we can make the appropriate referral at the appropriate time. So one of the things this article talks about is that people with COPD that is diagnosed, they all need to have a chest CT done. That kind of helps them figure out the phenotype. And that basically is the classic, like, are they a pink puffer or are they a blue bloater? You'll probably remember those terms from school or your PT exam. But it kind of helps them determine what the best course of treatment is going to be. And that's something that I've definitely had people come in who have not had a chest CT done, but do have diagnosed COPD. And so from my perspective, if someone comes in and they do have diagnosed COPD, that's one box for us to check. Okay, well, have you had a chest CT done? And if the answer is no, that's probably a referral back to their PCP, because this is a recommendation of pretty high level. The next recommendation is, of course, smoking cessation, because we know that no matter where you are in your history of smoking, that ceasing to smoke is going to allow for at least some lung degeneration. And that really is dependent on how long you've been smoking and like how many packs per day per year, right? So kind of figuring that out and getting people on the bandwagon is big. Like I know as PTs, we are hesitant about talking with people about some of these lifestyle things like smoking, weight loss. It's a hard conversation to have. And we know that people aren't completely uninformed. Like they know they're not supposed to smoke, that it's unhealthy, but still, like we can be a drop in the bucket. We can be that provider that says, listen, I know you understand that smoking is not healthy for you, but I need you to understand that if you continue to smoke, it could actually create this advanced thing called chronic obstructive pulmonary disease, where you might have to be on supplemental oxygen, where you might not be able to breathe very well. And these aren't just things that happen to 1 in a million. This is 10% of our population. So being able to use some of those numbers and just be realistic with people, like this is a big risk you're taking. And then again, being able to go the extra mile and provide a little bit more education, to say like, here are some resources. Here's the 1-800-QUIT-SMOKING-NOW number. That's actually what it is, minus the now. But being able to help them with that so that we can not only provide the information, but we can follow up. In 2 weeks when we see them again, we can say, hey, how's that smoking going? Like, are you getting on the bandwagon to quitting? Are you thinking about using the patch? What are you doing? Because I really believe this is important for you. The article goes on to talk about O2 sats, which is a measurement that we as PTs should be really comfortable taking. They say for any patient whose oxygen saturation level at rest is 88% or lower, those people are almost definitely going to be on supplemental oxygen. For people who at rest it's 90, those people are going to be sent for arterial blood testing to see if supplemental oxygen would be helpful. The other thing is we need to start taking O2 sat before we start exercising with patients, especially if we know they have COPD. Because what we need to look for is a shift of percentage points of 3 to 4 before we stop exercise or modify what their supplemental oxygen level is. Because if a patient comes in and they have known COPD and we, throw the pulse ox on their finger and we see that their oxygenation level is like 96%, okay, that's good to start with. But as we're exercising, if we're seeing that drop, if we're seeing that go below 92%, that 4% decrease, that's not necessarily safe. So the person's body is not accommodating the exercise appropriately. So that's a concern, right? And that's when we either need to stop exercise, modify exercise, or modify their oxygen level if they do have supplemental O2. So those are important things for us to consider. Now, we also know that people with COPD really need exercise, right? They need to be able to optimize the amount of oxygen they're getting in their body and in their blood to the tissue and their organs. And exercise is a great way to do that and to combat all of the other things that are going on and those other comorbidities that are correlated with COPD. So we know they need exercise. So we as PTs just really need to get better at thinking along those levels and thinking about measuring SpO2 before and during exercise to make sure it's not doing something that's inappropriate or unsafe, right? It's something also we need to be looking at with our other patients along with vitals, just to be screening and looking at some of those early factors, especially when patients, check the smoking box on their intake form. That's a cue to us. That should throw red flags and like sparklers in the back of our eyeballs or something like that, that lead us to then ask the questions of the patient about any wheezing, shortness of breath with activity. Do you find that you have a cough in the morning? Are you clearing your throat a lot? All those things that the patient may not be thinking are a big deal or may have attributed to something else, but we as clinicians, as a doctoring profession, need to be aware of so that we can do some of this screening earlier on. Now, the interesting thing is with COVID-19, we are going to start in the future to see some patients who have both COPD and have had coronavirus. And that's going to be very difficult. We know from reports that people who are more severely affected by COVID-19 are the people with more comorbidities and especially previous respiratory issues. So COPD would be a natural one that would preclude people that get COVID-19 to have a more severe response. The tricky part is with COPD, emphysema, chronic bronchitis, those kind of issues, it's more of an issue of getting breathing rates lower and getting air out. So things like pursed lip breathing, where you get people to breathe in through their nose and out through pursed lips to slow the exhalation rate. Those are really good tips to help people get their breathing rate, their respiratory rate under control. But for people with COVID-19, they actually have inflammation in the alveoli, which inhibits or prohibits gas exchange. So it's like if you have people who have suffered both, now we're going to have a whole host of new problems. Or it's going to make it exponentially harder to get these people back to fitness or more well-trained. But again, I think this is just another reason that as PTs, we really need to get better with our vitals, better at understanding oxygenation levels, and just better at checking some of these things and looking at the whole picture, right? Like check those boxes in the previous medical history. Don't discard them and say like, they're already taken care of. The patient said they're being treated. Check those things. You don't know, and we need to know in order to be safe. I mean, that is why Eric Chaconis and I put together the primary PT course, which has its second cohort going again in June. So for any of you who are interested, or if you feel like you need to know more about some of these vital signs and conditions that go with PT patients, check out the course. We'll be going again soon in June. But I hope this has been helpful. If you are seeing patients in the clinic currently, remember, if the patient comes in with COPD, there are certain factors that we need to be sure of. For people who come in and they might be predisposed to developing COPD, we need to make sure we jump on that bandwagon of really getting people to understand the importance of smoking cessation and just healthy life strategies. So let's jump in there. Let's be better primary care clinicians, and let's really join the medical community in helping to decrease the third leading cause of death worldwide. All right, guys, have a great day. Oh, the song of the day is Possession by Sarah McLachlan, because there's a line in there about take your breath away. All right, have a good one, everybody.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.